Hey, a quick shout out before we dive into today's episode. Million Podcasts has named Beyond the Mask the #1 anesthesia podcast of 2026. Congrats to Sharon, Jeremy, and everyone behind the scenes making this show happen. And a huge thank you to you for listening and sharing the show.
Welcome to Beyond the Mask. I'm your host, Sharon Pierce, and today's episode comes to you from across the globe. We're taping live in Australia at the International Federation of Nurse Anesthetists meeting. It's an incredible gathering of anesthesia providers from around the world, all focused on advancing our profession, improving patient care, and strengthening our global voice. Joining me today as a special co-host is Kevin Chem, and we're honored to be joined by Richard Henker, who brings a powerful perspective in global anesthesia care and his work connected to the World Health Organization. In this episode, we're diving into a critical conversation about something that has long been missing in our profession: the ability to consistently capture and leverage perioperative data. Without standardized data, our ability to improve care, demonstrate outcomes, and to advocate effectively is limited. We'll explore how the Operative Encounter Registry, or OER, serves as a simple point-of-care tool that allows anesthesia providers to capture essential surgical and anesthesia data, making our care visible in ways it hasn't been before. From tracking outcomes and complications to understanding case mix, this data has the potential to transform quality improvement, education, and resource alignment. And beyond our individual practices, we'll discuss how this work connects to a much larger global movement, informing policy, advancing initiatives through organizations like the World Health Organization and the Global Alliance for Surgical Obstetrical Trauma and Anesthesia Care. This is about more than data. It's about visibility, value, and the future of our profession.
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to Beyond the Mask, innovation and opportunities for CRNAs and advanced practice nurses, with certified financial planner Jeremy Stanley and CRNA Sharon Pierce. Jeremy Stanley has worked with CRNAs for more than 23 years, and Sharon Pierce is a former president of the AANA and the NCANA. Join us as we leave the operating room and learn the latest in the CRNA and advanced practice nurse industries. Beyond the Mask starts in 10, 9, 8, 7.
Welcome, Richard. Thanks for joining us today.
Dr. Henker, it's an honor to talk to you. We talk about representing the profession on a national level, but you're obviously doing it on an international level here. I want to hear about your background and how you got started in this endeavor, and that's created this very long resume that you have today.
Thank you so much, Sharon and Kevin, for having me on today, and it's great to be able to speak about this Operative Encounter Registry that we're working on. Just a little bit about my background. I'm faculty at the University of Pittsburgh. I actually went to part-time in 2022 at Pitt so I could go ahead and work more on some of the global aspects. I'm one of the officers in the Global Alliance for Surgery, OB, Trauma, and Anesthesia Care. And when you sign on as an officer, it's a 6-year term. So you're the secretary the first
6 years.
Secretary the first 2 years, the vice president the second 2 years, and then I'll become the president. I'm the vice president now. I'll become the president of this Global Alliance for Surgery, OB, Trauma, and Anesthesia Care in November. We have a meeting in Ghana with Mercy Ships and Operation Smile and G4 Alliance, and we have meetings for G4 Alliance every year in Geneva, and we work on influencing resolutions that are up for discussion at the World Health Assembly, and this year we have a resolution that we're working on a great deal, and I should discuss that a little bit. But then we also go ahead and work on advocacy for surgery, OB trauma, and anesthesia care. We have 3 nursing organizations in the group and about 70 surgery organizations and some anesthesiology organizations that are also part of this group. So it's a little unusual that they elected me to be the officer, and I'll be the president of a group that's mostly surgeons, and we have many neurosurgical groups. I also work, Jackie Rolls went ahead and asked me to help out with IFNA, so I worked on the practice committee, and I'll be stepping down from that role as the chair of the practice committee at the end of this meeting. So, but I also work with a group, I should chime in, Health Volunteers Overseas. And Health Volunteers Overseas has supported much of the work that I do. HVO has a very different philosophy than many groups that work overseas, in the sense that our goal is to support the nurse anesthetists that are over in those countries. So what I've done for years, I've worked 20 years at Anchor Hospital for Children in Siem Reap, and teaching. And it's not just me, it's other volunteers. And I have people that are here. One, I have our chief nurse anesthetist from Anchor Hospital for Children that HVO helps support to get here. And then we have some of the volunteers that help out at Anchor Hospital for Children that are also here at this meeting.
So you're like my good friend Jackie. You're never at home.
My home these days is actually Nagasaki.
What?
Really?
My wife, I met at the Simulation Center at the University of Pittsburgh. She was a visiting fellow at Weiser doing simulation. She's a physician. We got married, and she lived in the United States, got her MPH, and I pulled her into global health. And she ended up getting a job for the Lao country office for WHO as a consultant. She could work in the US. So she's also been pulled into the global health piece. And she's working on Doctorate of Public Health at Nagasaki University. I was visiting faculty there last year. And it allows me to go to Cambodia and Laos, where I do much of my work. I also teach in Taiwan, teach in Japan, and teach in Thailand.
Well, Kevin has a connection with Cambodia.
Yeah, my parents, they came during the genocide. So, I was meaning to talk to you. I've known you for a while. I've been meaning to talk to you because I want to go over there. I'm very eager to connect with the Cambodian nurse anesthetists, and it's really fascinating what you're doing out there.
We have a great connection here. So we have actually a past president of the Australian Society of Anesthesiology is Susie New, and she's at this meeting. And her heritage is from Cambodia, so she's from Cambodia. So I met Susie. She worked in critical care. She's an anesthesiologist. She worked at Anchor Hospital for Children. And then she also works with Song Sotia, who's here from Cambodia.
I did meet him, yeah.
They coordinate the yearly meetings for emergency critical care and operative care in Phnom Penh.
Wow.
And I've spoke at those meetings. And so I've met Susie there. I've met her at Anchor Hospital for Children. And Susie has also come to Lao Friends Hospital for Children. And I also work in Luang Prabang, Laos. And so I go between those two sites frequently. And that's where I continue to do some practice, and we do a lot of teaching.
That's amazing.
Sounds like there's going to be a lot of discussion after this podcast.
I'll get your information for sure. I would love to be involved in that. That's great. But we're here to talk about this Operative Encounter Registry.
Okay.
Yeah. Can you tell us about this? This is really new information to me. Like, what was the need, and how was the development process for it?
So here's what happens is, we get in the policy arena, and it's like we think these policies are really good policies, and we don't have data to support the policies. So, what we wanted to do is, and there's been a number of resolutions that have been passed with at the World Health Assembly. So the major one was 68.15 in 2015. Lancet Commission, John Mira from Harvard published an article on global surgery. That led to 2015, that same year, a resolution being passed on safe anesthesia and surgical care. A couple of years later, they're like, we need metrics on this. and they weren't getting the metrics in terms of looking at, was it effective to improve the surgical OB trauma and anesthesia care? And we just weren't finding out. So many of us do metrics in terms of workforce, and I'm going to present this afternoon on the OER here, and I'm going to present our workforce numbers, but what we need to look at is quality. So we really have to look at quality and what is impacting quality. So the OER is really looking at quality improvement locally, and then what we're doing is we're taking that data and we're going to go ahead and incorporate it into driving policy. The policy initiatives will be at the local, regional level, national level. So for instance, Sierra Leone has a whole group of hospitals they want in this, and it's going to help them look at quality, but then also look at policy. And of course, the policy piece globally is something that we have to go ahead and look at. So these resolutions, what we're doing is we're providing the data that looks at these resolutions that we've implemented to really evaluate, have we accomplished the goals that we set out with those resolutions? One of the things that WHO likes to do is they don't like us to work in silos. They want us to work universal health care. They want emergency, critical, and operative care part of primary care. And they don't like the term that's being used around many of the countries, NSOPs, National Surgery, OB, Anesthesia plans. And some of our groups are pushing that. WHO wants it to be part of a strategic healthcare plan for the countries. So they don't want a separate surgical plan. They want it incorporated. Mm-hmm. And they're pushing eco-care, and they want us to look at this as part of a whole way to evaluate the healthcare system.
So that's the term they're using, eco-care.
They're using emergency, critical, and operative care.
Okay.
They asked us to change our registry, the Operative Encounter Registry. They asked us to change that because they wanted the word operative in it. So we've changed that. And in fact, instead of calling it the Operative Encounter Registry, the term that we're supposed to use now is Operative Encounter Module, that is part of the WHO global registries or clinical registries. So, so we work very close with WHO on developing this Operative Encounter
Sounds like
Registry.
There's a lot involved, and I understand you're trying to get data for advocacy. As somebody who's been a registered lobbyist for 25 years, we can have all the data in the world. Sometimes it doesn't move the needle within the advocacy piece, so I'm wishing you luck with that. But how is the OER different from other surgical or anesthesia registries that we've had?
You know, that's a good point. One of the discussions that we've often had is, how do we get people to do this? And we've had many groups that come in and they're like, oh, we need to include this, we need to include this. And, you know, we started out with about 50 variables. And the piece that we've had to do is we've had to go ahead and we've had to decrease the number of variables, because otherwise people aren't going to fill this out. So we've done pilots. We've done pilots at 3 different places. One, Lau Friends Hospital for Children, and I've worked on that pilot. And we've had many of our nurse anesthesia students, or I should say residents, to be consistent with ANA, have assisted. They've used this as a DNP project to do this demonstration project at LFHC. Peshawar, Pakistan, and we're working on data with that group, and we have Michelle Smith, who's part of the global task force that Jan Setner is leading, and she's helping me with looking at that data. And then we also had a site in Kenya, where that was the demonstration project level. Next, we're about to roll out a pilot study. We have 40 hospitals around the world that are interested in the pilot piece, and we're going to be using 2 sites in Cambodia, 2 government sites. The Cambodia government's very interested in doing this, along with Joint Commission International. I have a good friend that works for Joint Commission International, Cambodia, and she actually will be at World Health Assembly. And then Lau Friends Hospital for Children and they may be one of the hubs, and we're working on funding as we speak. So we have a grant due today that I've been helping with and trying to get funding. And we're always looking for funding for this Operative Encounter Registry.
It just seems like a lot of relationships that you're toggling together to make this all happen.
The G4 Alliance, the groups are amazing. So, the president of G4 Alliance, who's attended the meeting here yesterday, is Neil Wetzig, and Neil's going to present with me this afternoon. He's a surgeon that worked in Brisbane for many years, but he worked globally with a group called Heal Africa, and for years he's worked in Congo. Anesthesiologist, World Federation of Society of Anesthesiologists is involved, so I've gotten to know the staff. Francis Peel is one of the people we deal with. Adrian Gelb, past president for WFSA, actually has been one of our advocates for nurse anesthesia globally. So we've had many, many groups. Harvard, Operation Smile, Mercy Ships. Many of these groups, they come together and they're part of G4. And our network is just incredible. It's allowed us, and the goals with G4 Alliance, certainly advocacy, working on policy initiatives. But one of the part of our strategic plan is not only the advocacy piece, but it's also the network. So what we find is working as a network, we're incredibly strong in terms of getting things done.
Let me ask you another question. What role do you think the IFNA played in putting us on this world stage? Because I've been around in anesthesia for a long time, 35 years, and my program director was Sandy Marie Ouellette.
Oh, yeah.
And, they helped start the whole IFNA organization. And in my mind, watching this over the years, IFNA has placed us in a lot of these world stages.
Oh, it has. So IFNA was huge. So Jackie is the one that really promoted my role, and I think it was Wanda Wilson that asked me to be and it was based on Jackie's advice. Jackie was key. She was actually one of the officers. She was the treasurer of G4 Alliance early on. And Jackie recommended to ANA that they have a rep because of my work in Cambodia and Laos. They recommended me, and Jackie recommended that I be elected to the board. I was put on the board. I've been the chair of the planning committee since 2019. So I'm planning this, and that's probably what boosted me into being an officer. So I've been the chair of the planning committee. It allows me to really have good oversight of the direction that G4 Alliance is going. We have an amazing meeting coming up before the World Health Assembly, so we often hold a meeting before. We discuss resolutions, we go through, we talk about what's our strategy to go ahead and push some of the member states, the countries that are going to go ahead and be voting on these. And in this case, we've been going to many countries to go ahead and support a modification of the resolution that is going to come up on emergency, critical, and operative care. And one of the things we found in this resolution, there's not so much on operative care, and we want more on anesthesia and surgery in this. So we've made modifications to this resolution, and it also includes metrics, the Operative Encounter Registry. We've gone to our country states that work with us and see if anybody's interested. And one of the country states is, or the member states, very interested, and we're working on the language for them, and we're working with them. They have a 2-minute time frame to present on the World Health Assembly floor, and we're working with them on the text and presenting the modification. And then we're also lining up other countries to support that modification for this World Health Assembly resolution. So our current executive director, Colin McIff, Neil and I wrote up the modification, and now it's going to hopefully at least go up and be discussed.
You've probably wondered at some point, should I stay W-2 or go 1099? And more importantly, what would that mean for my income? AANA has launched a new 1099/W2 income comparison calculator designed to help you compare W2 compensation with potential 1099 earnings in just minutes. It also helps you understand how taxes, deductions, and expenses could impact your take-home pay. Try the 1099/W2 calculator today and see how your potential earnings compare. Visit aana.com/1099 calculator to explore the tool, or check this episode's description for the link. The 1099/W2 income calculator, helping CRNAs better understand the financial side of their career choices. Remember, that's aana.com/1099 calculator.
Okay, so we're talking about all this data being collected. Can you give us a specific example of what you're learning about? What are you collating? What is in this OER?
So what's in the OER is, for instance, we're interested, what are the indications for surgery? What types of procedures are done? Who are the anesthesia providers? And I know there's been a lot of discussion about...
That's hard to find out. That's the problems we have in the United States. I hope it's easier everywhere else.
It's what we find is, I remember people would ask me, so I didn't know they had nurse anesthetists in Cambodia.
Because they're masked.
And it's like, they do.
Yeah.
The majority, if you look at the WFSA report that Jackie participated on, the majority of anesthesia providers in Cambodia are nurse anesthetists. Okay, if you go to Thailand, nobody realizes that there's nurse anesthetists in Thailand. So I've been a visiting professor in Thailand on a number of occasions, and I went to the Nakhon Phanom Provincial Hospital, and it's like there's 6 nurse anesthetists and 2 anesthesiologists in a provincial hospital. And I'm like, and they're practicing independently.
Yeah, there's
Sounds
no TEFRA
familiar.
rules. There's no 1-to-4 ratio over there, I'm assuming.
Is it masked there for the same reason it's masked in the United States? Because billing. That's the reason why we're masked in the United States. Just like at one of the hospitals I work at, unless you dig into the record, you don't know that I gave the anesthesia. It just shows up with them. And Lorraine Jordan used to talk, you probably remember Lorraine.
Oh, I know
Used
Lorraine
to talk about how difficult it was for the foundation to get data because we don't show up. Only the anesthesiologist, because your data comes from billing data.
Yeah, and there's many reasons, but it's covered up. I've done a lot of teaching at different levels in Thailand. So for a month I was in Nakhon Phanom. I've been visiting faculty at Mahidol University at Sri Raj Hospital, doing simulation and taught in their nurse anesthesia program in addition to their department. And it just amazed me how many nurse anesthetists they have. And they use their nurse anesthetists very similar to some of our practice in the United States. So in the rural areas, you're independent. In some of the larger medical centers, it's team. So it's very similar. It's
Who
very
knows,
similar.
Kevin? You might be practicing again in Cambodia.
Yeah,
Yeah.
that would be very interesting to see.
So, as our listeners are listening to all this, and it can be overwhelming, just me listening, and I was president of AANA, and this is kind of overwhelming for me to listen to, but about everything that's going on. Anesthesia providers that are listening to this, and we're heard in 125 countries, how can they use the data that you're collecting?
I think we are very interested in looking at, the quality and the outcomes and who's actually providing the anesthesia. What types of anesthesia are they providing? What are the procedures? And there's many things out there, and we want to look at that and help that drive our practice. There's a study that came out October 2024, and there's a group in the UK, Birmingham, and they published a study looking at ilioinguinal blocks and treatment of hernias. Huge issue around the world. It's fascinating because they're having physicians with no anesthesia training provide ilioinguinal blocks, and they found that actually outcomes were almost better compared to doing these procedures with general anesthesia. And because they'd be in the hospital longer with general anesthesia, more complications, ilioinguinal blocks are definitely the way to go. So do we do ilioinguinal blocks in the United States?
Not
No.
really.
No.
Yeah, no.
And what I love to do is I bring students, I have my nurse anesthetist now in Cambodia and Laos. I have them teach students and I supervise the teaching. one of the things that amazes the students, they're like, wait, why don't we do ilioinguinal blocks in the United States? And they realize that, wait, I used to think that the United States did the best and greatest anesthesia and provided the best health care. And it's like, we don't do ilioinguinal blocks, and the patients get out. We give them some paracetamol along with their block, and they can go home and they do great. If they receive general anesthesia, you end up having a lot more complications post-op.
Well, I will say, Americans are kind of different people. I mean, I know that in some Asian cultures, for uppers, EGDs, they do them without sedation. You tell somebody in America they're going to do something without sedation, that's not going to work out.
We're spoiled here.
Getting back your point, we're interested in looking what are the procedures, what's the anesthesia. We look at monitoring, we look at timeouts, we look at blood. The outcomes, and we used to have 3 outcome measures. We'd have live, died, and unstable. And
that's pretty stark.
It is. Yeah. And we've just gone to live, died in terms of our outcome measures. But we're looking at huge numbers. So Pakistan, for instance, they had live, died at discharge from the OR, and I think it was like 0.5%. And then we looked at live, died at 24 hours. And those are some
of the... You mean
not
not 30 days, the way the ASA in the United States does?
What we found, I know. What we found is the most difficult variables, and part of our demonstration project was feasibility. Okay. We found that we did try to do on discharge, and we found that's a difficult piece because we can collect all the surgical data right then and there in the OR. And some places they have data collectors. Lau Friends Hospital for Children, the nurse anesthetist were entering the data.
Wow.
So, but what we found is the data that we could collect that day, easy for us to get. Trying to get the discharge data, that was a tough piece for us to get. So we've adjusted the Operative Encounter Registry based upon that demonstration project, and we'll adjust again based upon the pilot. The pilot is actually going to be using a WHO platform called DHIS2 for collecting data. And they use that for many things. And I'm going to present some things today at the IFNA that are from that database.
Talking about this OER, what's the goal with it in terms of advocacy for access, anesthesia, surgical care? Like what is the overarching goal of having this OER?
Well, and I put this in one of the grants that I wrote, and that is that I want to look at, what is the comparison of anesthesia provider in terms of outcomes?
And that's a biggie.
And
be careful with that.
So when we look at anesthesia provider type and we look at outcomes, I'm passionate because I believe nurse anesthetists are the key to providing access, especially in rural areas of many of these countries where they don't have access to care.
Yeah.
So we know that access to surgical care and anesthesia, we find that many of the physicians in anesthesia, they don't go to the rural areas.
That's so interesting.
In Luang Prabang, we have one anesthesiologist in the 4th largest city in Laos.
Huh.
So what we need to improve, we want to improve access to surgical care, throughout countries. In Laos, they have 600 cases per 100,000 of the population that have surgery. What is it in high-income countries? It's 10,000 cases per 100,000 cases per year.
All right, say that one more time because that is impactful.
It is very impactful. So the data for the number of cases in Laos per 100,000, they have 600 surgical cases per 100,000 per year.
Yeah.
United States, Sweden, other countries, and the data is a little old for the US, other countries like Australia, it's over 10,000.
So 9,400 people might need surgery but don't have access.
They don't have access.
Wow.
So what we find is we don't have access to surgical care. What do I want to find out? I think that nurse anesthetists are the best way to improve access to anesthesia care in many, and we've already found that out. Kenya, Kajabi Hospital, Mary Mundai is amazing. Mark
Mary.
Newton, Vanderbilt, they do a great job. They're the model.
She's amazing. We've had
She's
her on
amazing.
the podcast.
What we want to do is we want to say their model works, and we want to get the data to show that that works, and we want to start pushing to use that model around
When I
the
was
world.
AANA president, I used to say, what was the question? The answer is nurse anesthetist. I don't care what the question was. The answer is nurse anesthetist. And that's what you're basically saying
Yeah.
right now.
Yeah.
So if I'm on the ground, given anesthesia in the trenches, and I hear this podcast and I say, what can I do to help? And what can I do to help with this endeavor? Or how can I access it if I want to look at outcomes data? Is there a way to do this?
You can't really look at, even G4 Alliance is not allowed to look at the outcome data from the individual hospitals.
Okay.
And so we're going to be working with them. We want to go ahead and we want to see if we can look at those individual hospitals to see, if we can look at their data and see if they're, what the issues are that they're having. In terms of what we're doing, please, we keep pushing to, we keep publishing things. We've got many publications in the works. Please support, what we're doing in terms of policy initiatives, just keeping track. It's hard to push if people work in particular countries. They have connections with ministries of health. And, that's very helpful for us. What I find is, we have many people that love to do missions and go overseas for 2 weeks and do cases.
Yeah.
Make sure you connect with ministries of health,
That's a good point.
governments.
Yeah.
And the key with those is make sure you're coordinating with the strategic plan that is going on in those countries. Mission trips, and I hate to say this, but mission trips can almost be hurtful in some respects. So I have a group that comes in from Singapore to Lao Friends Hospital for Children. They bring their own anesthesia providers, and they don't allow them to do any anesthesia during those cases. The goal should be sustainability, and it should be teaching, facilitating them, helping them do the anesthesia in those cases. Instead, they have them run for supplies. Do I want that surgical group at Lao Friends Hospital? I don't. I really don't want them because they're not promoting sustainability. So if you're going to do mission work, make sure you coordinate it with Ministry of Health. You should be, when you do your mission work, you should be working with the existing providers. There should be training. It should be collaborating with them. And they're going to be teaching you. The Singapore group that came in, I thought it was so interesting. We have a draw-over vaporizer in one of our rooms.
Holy cow.
Yeah.
Holy cow.
And what we do is they don't know how to use draw-over vaporizer. And actually, when I take my students there, they're like, Rick, how do we use this? And we developed a PowerPoint on how to use a draw-over vaporizer. And we spent a lot of time teaching. So the Singapore group, they don't even know the equipment there. And they come in and it's like, teach us how to use your equipment, but then we're going to go ahead and provide the anesthesia. And it's like, it's just not right. It's just not right.
Well, as we kind of wrap up here, and I know we could go on for a long time with this subject, is there anything you would like to leave our listeners with?
The thing that I try to do is I provide some updates on occasion, and AANA puts those in their communications. And I'd like to thank AANA for the fact that they pass along much of that, those communications. And appreciate AANA's support for the work that we do for G4 Alliance. They're very active. I'm very excited that Jan Setner is going to be leading that global task force. I also like to thank Jackie Rolls for all the work that she has done to kind of provide the path that I've been able to take with G4 Alliance and the work that we do.
We appreciate everything that you are doing, and we'd like to extend to you, if there's ever any new information you feel like that our listenership needs to hear, you know how to get in touch with me, and I believe you're going to have to make Kevin leave you alone after this.
Yeah, we're going to have to talk. Yeah, I really want the connection. That'll be great.
And we'd be happy to put that information out. But thank you for joining us today. I look forward to learning just a little bit more about this. You know, I think I'm a pretty plugged in member, and I'm a good friend of Jackie's. I hear from her a little bit about some of this stuff, but I had no idea the depth of what you're doing. So thank you so much for everything, and thanks for joining us.
Thank you for tuning in to Beyond the Mask. If you enjoy the show and want to help us grow, the best way to support us is simple. Leave a review on your favorite podcast platform, share the show on social media, and tell your friends. Your word of mouth is what keeps us going strong. We're proud to consistently rank in the top 50 medical podcasts nationwide and to be #1 in the CRNA community. All thanks to listeners like you. Your support helps us stay there, and we couldn't do it without you. We'll see you on the next Beyond the Mask. Hey, a quick heads up for those of you who like travel and learning combined. Nurse Anesthesia Update is coming up November 30th through December 3rd at Atlantis Paradise Island in the Bahamas. This CRNA-focused program covers practical anesthesia topics, common challenges, and emerging trends, and features Beyond the Mask host Sharon Pierce, of course, former AANA president, as part of the faculty. You can earn up to 20 Class A CE credits, including pharmacology, while enjoying one of the most incredible destinations out there. Check the link in the show notes to learn more and register.